Okay, ladies and gentlemen, we're going to talk about the respiratory system here. This is going to be the first part. The first part is going to talk more about what's known as ventilation. You can break breathing down into various components. The first part we're going to talk about here is what's known as ventilation. Ventilation is getting air into your lungs. It doesn't say anything about how well the gas exchange is going on inside your lungs. It just says, I've got to get air in. How do I get air in? Do not underestimate the power of ventilation. So let me, will it not let me? Oh, it will let me. Okay, here we go, yeah. Right, so, it's chapter 19 in your book. So here's where it all starts. A little bit of anatomy review. Let me get the right thing that I want. I want my pen. Okay, so you have your nose. Remember the external nares. This is where air comes in, or it can come in through the mouth, right? Come in here, or up there. That's how you get air in. Right. We're going to talk about how you get air in, which is a little bit more complicated than you think. But remember, you break down the pharynx is the combination of your oral cavity and your nasal cavity, right? Where air goes and where food goes. And they share common tubes, if you will, to get to where they're going. Obviously, you want them to go where they're supposed to go and not where they're not supposed to go. So when air comes in, it has to go past through the nasopharynx. So that's the first part of the pharynx. That's air only back there. You also have, remember, you have this auditory tube, or eustachian tube, it's sometimes called. That's to equalize pressure between your ear, the middle part of the ear, and the eardrum, and the outside world. And then you move into the oropharynx. Oropharynx is where, when you swallow, that's where food goes, but that's also where you breathe. So when you swallow, two things happen. The epiglottis drops over the trachea to keep food from going into your lungs, and the uvula in the back of the throat, the little hanging thing back there, also lifts up to block any more air from coming in through your nose, so that when you swallow, the food goes into the epiglottis. And, it goes past the epiglottis into the esophagus here. So that's where you want food to go, but you don't want air to go there. So air will be diverted into the larynx, down into the trachea, etc. So oropharynx is where food and air share a similar space. The laryngopharynx is now where you're going to start to differentiate and differentiate into the esophagus and the food-bearing system, and into the trachea, into where the respiratory system goes. So this is just a brief review of all of those tissues. Right, so we divide the respiratory system into two big areas. We call it the upper respiratory tract here. And that includes everything up to just about the larynx. Just about the larynx, right around the laryngopharynx, where things start to separate out. We call that the upper respiratory tract. The lower respiratory tract includes everything from the larynx, that would be the trachea, the bronchioles, and the lungs themselves, and we consider that the lower respiratory tract. So we divvy up things that way. Functionally, the way things are divvied up is we have what's known as a conducting zone. A conducting zone means, how do you get air in? What are the structures that get air into the lungs? You conduct air into the lungs. It doesn't say anything about what happens to the air once it gets to its destination. It's just how you're going to get it there. That's the conducting zone. The respiratory zone is where the business end of it is. Once the air is in there, then you need to extract you need to take in what you need, which of course is oxygen, and you need to get rid of carbon dioxide, which is a waste product from cellular metabolism. That's in the respiratory zone. We're going to talk about that in another lecture. So conducting zone is really where we're going to be, functionally where we're going to be focusing. But the conducting zone will include upper and lower respiratory tracts. All right, so here it is. Here's the, you can see here's the larynx up here. And then once you get below the larynx, now you're getting into the trachea proper. And then, of course, air is going to flow down here. The air can go in two different directions. Does it go off to the right side? And remember, you're looking at this person as they are looking at you. So what I just drew, the arrow I drew, is the right side. This is the left side. So you have two main bronchi. I have a right main bronchus and a left main bronchus. Right? So that's the split, the right main bronchus, left main bronchus. And they get into the lobes of the lungs. So you have lobar bronchi. The left lung has two lobes, so you have two lobar bronchi. And you have three lobar bronchi on the right lung because you have three segments or three sections to the right lung. And then you can follow the breakdown over here. They've got a whole table over there showing you all of the branching. So it's like an inverted tree. You kind of knew that already. They all have names. I'm only interested that you know the main bronchi. So you have a right and left main bronchi, and then you have three lobar bronchi on the right lung and two lobar bronchi on the left lung because of how many lobes you have there. So the cell types. The only place functionally where you're doing any gas exchange is way down here when you get to alveoli. Okay? Alveoli, you need flat cells, simple squamous epithelium, so that you can get good gas exchange. And that's the only place where gas exchange is happening in the lung. Before that, everything is conducting. It's all a conducting system. So when you breathe stuff in, you're breathing in whatever is in the air. Pollen, dust, soot, whatever it is that is coming into your lungs. That's why you have to have pseudostratified ciliated columnar epithelium with these cells. See these special cells here? This thing is called a goblet cell. Goblet cell creates mucus. It puts mucus on top of the cilia and the pseudostratified ciliated epithelium. If that dirt and crap gets caught there, then it will take the debris material and bring it out to a place where you can cough it up, or it can be swallowed into the esophagus and you get rid of it. But as you go lower and lower and lower down into the respiratory system, the conducting system cells end here. So these are all conducting cells. They get thinner as you go along, but none of these cells are doing any gas exchange at all, no respiration at all. It's only when you get down to the simple squamous, oops, did I just do that really? Oh, jeez. All right, I'll see if I can edit this out. Otherwise, it's going to look pretty weird. Okay, so all of my annotations just disappeared. Sorry about that, but you get the idea, right? So it's only you get gas exchange in the simple squamous epithelium at the alveolus. Otherwise, you're just conducting air into the system and then trying to clean it up as it goes along. This is your main destination, the alveolus, right? So anything prior to an alveolar sac, anything prior to that does no gas exchange. There is no gas exchange in the interlobar bronchial. There is no gas exchange until you get to where anything that says alveolus. These are the kind of the berry-like structures of how alveoli are built and presented. And then you see the extensive circulatory system, the capillarization of these structures. Incredibly intense capillarization. Remember, the pulmonary artery brings deoxygenated blood from the right side of the heart, the right ventricle specifically. This comes around here and encapsulates or encompasses the entire alveolus, and then you get gas exchange, and then you get oxygenated blood out a pulmonary venule, and then that's going to deliver blood to the left atrium. But remember, down to the terminal bronchioles are part of the conduction pathway. There is no gas exchange, conduction pathway. They just transport air, that's it. They don't take part in gas exchange. Structures between the respiratory bronchioles, right here, between the respiratory bronchiole and the alveoli are part of the respiratory pathway. They contain alveoli and they do perform gas exchange. So gas exchange starts there, respiratory bronchiole, and on into the alveolus. These berry-like structures, blackberry-like structures. Here is an extreme close-up of what an alveolus looks like, and the alveolar membrane. And so you have this cell, right? That's an alveolar type 1 cell. That's the simple squamous epithelium that we just described in previous slides. But there's another kind of cell. There's another kind of alveolar cell called the alveolar type 2 cell. That cell produces a slippery material called surfactant. Surfactant helps to keep the alveolus open, and it reduces the tendency of the alveolus to collapse in on itself. It keeps it open. And so you need the type 2 cells to make surfactant to lubricate the inside of the alveolus to allow gas exchange to occur. It turns out that this new coronavirus that's going on, it tends to decrease the activity and attack alveolar type 2 cells, and so you get less surfactant, and so the alveolus does not want to stay open. It wants to collapse. That makes it very difficult to do the thing that's happening over here on this other side over here. This is where you're getting gas exchange. Here's a red blood cell coming through a capillary. Here's the alveolus right here. Okay. You need to get oxygen out of the alveolus into the red blood cell, and you need to get CO2 out of the red blood cell and the blood itself, the plasma of the blood, and you need to get it into the alveolus. There's three layers you have to cross here. You have to cross the alveolar epithelium. You have to cross the basement membrane that lines the alveolar system, and then you have to get through the capillary endothelium. Those 3 layers, you have to get gas. You need these things to be as thin as possible. That will allow O2 to diffuse into the blood, CO2 to diffuse back into the alveolus. Thin, thin, thin. You don't want any more fluids or secretions in the alveolus than you absolutely need. So here's another version of this. Blood flow. Blood flow would mean, of course, this is coming from the pulmonary artery or arterioles. Blood's flowing down here, deoxygenated. Here's the alveolar wall. So these would be the type 1 pneumocytes. And then you would have a basement membrane, and then, of course, you have the lining of the capillary endothelium. So O2 in, CO2 out. O2 is going to be higher concentration in the alveolus than it is in the blood, so it wants to diffuse down its concentration gradient. CO2, on the other hand, is higher concentration in the blood. It wants to diffuse into the alveolus down its concentration gradient. Eventually, things equilibrate, and blood flows out of the alveolus, out of the lung, into the left atrium. Remember, you want things to flow down concentration gradients. That's the easiest way to get things to exchange. Here's a close-up. These are micrographs. Here's a bronchiole. The bronchiole is just a tube. They're just smaller and smaller and smaller branching tubes that conduct air into the alveolus. Here is the business end, basically. What you're after is why you're trying to get the air down here. You're trying to get it into an alveolus here. You're trying to get gas exchange through these very, very fine capillaries. These are just pictures of that system. Okay, now you got to get used to terminology. The terminology now, of course, you think of it, oh, I inhale and I exhale. Well, not physiologically, you don't. And it's also not called breathing. Really what you're doing is ventilating. Ventilation is the act of bringing air into the lungs and getting air out of the lungs. Bringing air into the lungs is called inspiration. So you get used to this terminology now. inspiration. Now you can say, ooh, I'm inspired, or I painted a great painting. I was inspired. I got an inspiration from nature, or something like that. Nope, sorry. Doesn't work that way here. Inspiration is bringing air into the lungs. Expiration is sending air out of the lungs. So inspiration, expiration. I know it says inhalation and exhalation. That is true, but those tend to be words that we don't focus on in physiology. Physiology, it's called inspiration and expiration. So here's a definition of what's called a respiratory cycle. One inspiration and the following expiration. Try that with me now. There, that's a respiratory cycle. You do that on average, most people do that at rest, about 12 to 20 times per minute. Respiratory cycle, inhale, exhale, or inspire, expire. That is one respiratory cycle. The only reason you can expand your lungs at all is because of the tissue that surrounds the lungs. So that tissue is called a pleura. That's the lining. There's two parts to a pleura, as there are two parts to a pericardium. Well, there's actually three parts, but there's two big important parts in a pericardium, and the peritoneum inside your gut and your abdominal organs. The pleura serves a very special purpose, though. So the visceral pleura is a connective tissue that is on the surface of the lung itself. It's very, very tightly adhered, tightly bound to the surface of the lung. Right, so that will be this tissue here. So this would be more the visceral pleura. On the outside of it is this tissue called the parietal pleura. And these are called serous membranes. And serous membranes make a fluid. The fluid is called a serous fluid. It's a slippery fluid, right? It keeps the resistance low. What happens inside this area right here, in between the parietal pleura and the visceral pleura, that slippery fluid is in there, but there is also a negative pressure. Now we tend to refer to these pressures as negative pressures rather than a vacuum. That's how people want to refer to this. But it's a negative pressure. So negative pressure means the intrapleural pressure. Remember, intrapleural, in between the pleural membranes, which is the parietal and visceral pleura. There is a negative pressure. What that does is that essentially sucks, if you will, it kind of sucks the lung tissue itself, what's called the parenchyma. The parenchyma of the lung is sucked against the parietal pleura, and so it's held there. As long as you keep that intrapleural pressure in between there, you can breathe. If that intrapleural pressure is interrupted for any reason, the lung will collapse. Right? The medical term for that is called a pneumothorax. 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 Pneumothorax is a collapsed lung. Lungs collapse because you have lost the intrapleural pressure. You can no longer expand that lung. You have to have that in order for lungs to expand. So here's how they expand. If you sat at rest and tried not to breathe, so do that for a moment. What's happening there is the inside pressure inside your lungs is equal to the outside pressure. So barometric pressure, or what's known as atmospheric pressure, at sea level. Now we're not quite at sea level here, but at sea level it's 760 millimeters of mercury. What does that mean? That means that a column of air, the air itself, is putting pressure on you. You don't feel it because it's there all the time. That pressure is equal to 760 millimeters of mercury. So if you don't breathe and you have your mouth open and your nose open, it's hard to close your nose, and you're not breathing, your intrathoracic pressure. The pressure inside your chest is equal to the outside pressure. Okay? You would say, I'm not breathing. That's right, you're not breathing. And you're also not ventilating. So how do you get air in? Well, you have to create what we would consider negative pressure. You'll think of it as a vacuum. But you have to create negative pressure. That's done primarily by the diaphragm. The diaphragm is a muscle that lines the bottom, all along the bottom of both lungs. When it contracts, it does what this plunger is doing. So that plunger goes down. So it's pulling down. As it pulls on the lungs, it pulls on the pleural membranes, it expands the thoracic cavity. It makes the thoracic cavity bigger. As it does that, it creates a negative pressure. Now you can think of it as a vacuum, that's fine. Creates negative pressure, and then air, of course, automatically wants to rush in when the diaphragm contracts. That's what you will call breathing, but that's what we call ventilation. Ventilation depends on your ability to create negative pressure inside your thoracic cavity. So that would be called inhalation or inspiration. Inspiration depends on the ability of the diaphragm to create increased volume inside the thoracic cavity, but also create a negative pressure so that air will rush in. That's inspiration. How do you get the air out? There's a couple of ways you can do that. Of course, the way that they demonstrate it here is that you're pushing at it. You're actively pushing it out. But most quiet breathing is done. Quiet breathing means just sitting here and just breathing in and breathing out. Of course, you're thinking about your breathing now because I'm talking about it. But when you're breathing in and breathing out, that's called quiet breathing at rest. Say in a chair or lying down on the ground or whatever. Most expiration is caused by elastic recoil. So you've breathed in, you've contracted a muscle, you've created increased volume inside your rib cage, the thoracic cavity. That creates negative pressure. Air from the outside world comes in to your increased volume of the thoracic cavity. That's inspiration. Now you relax those muscles. Your diaphragm relaxes. The rib cage now just rebounds from the recoil. And so most of the time, expiration is a passive process at rest. Inspiration typically is an active process at rest. Right, so here it is. Now we got to get into a little bit of physics. Boyles Law. Boyles Law just says that the pressure and volume of gases are inversely related. What does that mean? I actually just told you that in layman's terms in the previous slide. When the diaphragm contracts, it increases the volume of the thoracic cavity. So in picture B over here, this person is inspiring. They're creating negative pressure because their diaphragm is contracting. When the diaphragm contracts, it makes a larger area inside the thoracic cavity. That larger area has negative pressure associated with it, and so now atmospheric pressure hasn't changed. That doesn't ever change. You have to change the pressure inside your thoracic cavity to get air in and to get air out. Inversely related simply means as I increase the volume inside the thoracic cavity, I am decreasing the pressure. And that's the key. If you decrease the pressure inside the thoracic cavity, see there it is, you decrease the pressure. So if it's outside at 760 millimeter of mercury, you don't have to decrease it much. You say, oh, 758, well, that's not much. It's enough. That's all it takes. Right? 2 millimeters of mercury, that's all it takes. Air will now fill your increased volume inside your thoracic cavity. When you relax, the elastic recoil of all the tissues, the ribs, the muscles, the pleural lining, the relaxation of the diaphragm, all of these things will now bring your thoracic cavity volume back down to where it was. So you're decreasing the volume, which increases the pressure inside the thoracic cavity. Now air will get pushed out, back out into the atmosphere. That's breathing. That is ventilation. Now, remember, phrenic nerves innervate the diaphragm. The phrenic nerve tells the diaphragm contract. When it contracts, when the diaphragm is at rest, it's shaped more like this, more like an umbrella. That's at rest. When it contracts, it's more flattened, has a flatter profile. So it contracts, and when it contracts, it pulls down that way. And so you see that here. You see that demonstrated in these two pictures. As it pulls down, it helps to expand the rib cage as well, and there are other muscles that do that too. You get a flatter profile, increased volume inside the rib cage, decreased pressure inside there, air flows in. Elastic recoil, you relax. That decreases the volume inside the thoracic cavity, but it increases the pressure. That's what inversely related means. So, here's inspiration. We've already talked all about these points. Right, so during normal, quiet inspiration, the diaphragm and external intercostal muscles have more to do with inspiration. You'll see the internal intercostals have more to do with expiration. But here they are. Normal, quiet inspiration, the diaphragm and external intercostal muscles enlarge the size of the thoracic cavity. All right, it gets bigger, more volume, less pressure. Lung expansion is aided by surface tension in the pleural cavity. Right, I just told you that. The visceral and parietal pleura have an intrapleural pressure, a negative pressure. So basically, the visceral pleura is sucked up against the parietal pleura, and that vacuum force is maintained. And when you increase the volume of the thoracic cavity, it simply pulls on the parietal pleura, which pulls on the serous fluid, which pulls on the visceral pleura, which pulls on the lung tissue itself and expands it. Remember, the type 2 pneumocytes produce surfactant that reduces surface tension in the alveoli. That helps the lung to expand. A deep, forced maximal inspiration requires contraction of several other muscles to enlarge the thoracic cavity even more. We're going to get to how that works. So here it is. Here's the muscles. Diaphragm. The diaphragm is absolutely number one, the most important. Probably does at least 3/4, maybe up to 90% of breathing, of inspiration, comes from the diaphragm itself. So if you have somebody with a spinal cord injury that is below the level of C3, they will have diaphragm function and they will be able to breathe on their own. If their injury, so that's right about here, if their injury is higher than C3 or higher, then they will lose some ability to contract the diaphragm, or maybe all the ability to contract the diaphragm, because the nerve roots that innervate the diaphragm start at C3. So the rhyme that we say for the phrenic nerve that innervates the diaphragm is C3, 4, 5 keeps the diaphragm alive. C3, 4, 5 keeps the diaphragm alive. So C3, 4, 5, those nerve roots, parts of those create the phrenic nerve. The phrenic nerve innervates the diaphragm. The diaphragm is primary muscle of inspiration. That's how it works. So if you have a C5 or C6 spinal cord injury, they're going to be able to breathe on their own. These are called accessory respiratory muscles, sternocleidomastoid, the scalenes. When people are under a lot of pressure or they're feeling very anxious or nervous, you'll see their neck muscles tense. Those muscles are accessory respiratory muscles. Pectoralis minor is also another accessory respiratory muscle. Diaphragm is the primary one. External intercostals are also primary for inspiration. Now, Maximal inspiration. So go ahead and take a very, very deep in-breath. You'll feel your rib cage will expand tremendously. You'll feel your neck muscles. You'll feel chest muscles. You'll start to feel everything pulling on your rib cage to expand it to its maximal volume. So, here are the events. You know we like our event questions, right? What order do these things happen in? Impulses go to the phrenic nerve, the diaphragm, contracts the diaphragm. Dome-shaped diaphragm moves down, becomes less dome-shaped, but it increases the volume of the thoracic cavity, which decreases the pressure. See, intra-alveolar pressure. It decreases the pressure because of the inverse relationship between those two. Atmospheric pressure greater than intrathoracic or intra-alveolar pressure forces air into the respiratory tract through the air passages. The lungs fill with air. There you go. That's inspiration. You got to get the air out, so it's called expiration. Now normally, for normal resting, right? Normal resting expiration come from elastic recoil. That's your biggie. Elastic recoil is the primary way at rest of getting air out of your lungs. It's simply returning the original shape, the original tension on those tissues. It usually happens with no muscle force at all. Everything returns the original shape. Surface tension that develops on the moist surfaces of the alveolar linings shrinks the alveoli. So the surface tension, even though you're reducing surface tension with surfactant, you've expanded the alveoli. That alveolus will, under surface tension, the water in there, because it's humid, that water in there will allow the alveoli to shrink. Just a tiny bit. But you have trillions of alveoli, so it doesn't take much. So you combine these factors. Combined factors increase intraalveolar pressure about 1 millimeter. That's it, 1 millimeter of mercury. That's a tiny little pressure. But that's enough. Right? Resting, normal, quiet expiration is a passive process. You don't need muscles to breathe out passively when you're at rest. Now, you can force air out, so go ahead and do that. So take a breath in, a short breath, regular breath. Now breathe out. As you squeeze more and more and more air out of your thoracic cavity, you're finding more and more muscles. The abdominal muscles will start to squeeze very hard. You start to squeeze your chest. You start to squeeze the rib cage. You're really, really pushing all of those muscles that are attached to the rib cage that will squeeze the rib cage down, force air out. That's called forced expiration. So here are the muscles that do that. Typically, the diaphragm doesn't have anything to do with expiration. Right? So elasticity at normal expiration, normal recoil, elastic recoil is a passive process. But if you're going to force things out, you're going to have to get the internal intercostals to pull the ribs down. The abdominal muscles are going to play a huge role in squeezing and compressing and decreasing the volume of the rib cage. And when you decrease the volume, remember that increases pressure. If you decrease volume, you increase pressure. Here's the events in expiration. Right? Diaphragm and external respiratory muscles relax. They're not needed. Elastic tissues in the lungs stretch during inspiration. They recoil. Elastic recoil, we'll call that. Tissues recoiling around the lungs increase intra-alveolar pressure, so you're decreasing the volume and increasing the pressure. Air is forced out of the lungs. That's expiration. Now, so we have lots of different volumes of inspiration and expiration that we define. When you are at rest and you're breathing in and breathing out, so just take a few breaths like that. Just relax. Think about your breathing for a moment. What you're doing there is, that's at rest breathing. That's referred to as tidal volume. So think of a tide, right? You're at the beach, waves come in, waves go out. That's why it's called that, because the air is coming in, air is coming out. It's a relatively passive process. The inspiration is slightly active. The expiration is pretty much passive. That's called tidal volume. That's about 500 milliliters, 500 ml, tidal volume. So you could go like that forever. But of course, you can bring in more air. You have extra space. That extra space is called inspiratory reserve volume. So you have that volume. You have it ready if you need it. If you're just breathing quietly, you take a big breath in. The amount of air that you brought in is called the inspiratory reserve volume. That is from a normal inspiration to your maximal inspiration. So this red bar here. It won't do me any good to draw a red line on it because you won't see it. So from normal inspiration to maximal inspiration is called inspiratory reserve. Now, if you add the normal at rest inspiration, this volume, that's your normal at rest inspiration, and then you add to that the inspiratory reserve, you're going to get inspiratory capacity. Inspiratory capacity means how much air can I bring in? That's how much you can bring in. You can bring in 500 milliliters plus this extra volume, which is, on the order of 2.5 to 3 liters of extra air that you can bring in. Your inspiratory capacity. All right? So, now, of course, you have expiratory extra, right? You could breathe out more. So, get to, I can't find my little pointer. Oh, there it is. Haha, found it. All right, so if you're at rest, you let the air come out. Then breathe out as much more air as you can. That is your expiratory reserve volume. That's how much extra air you could push out of your lungs. And then it turns out that you cannot get all of the air out of your lungs. Even if you breathe and squeeze and push, you still cannot get all of the air out of your lungs. The amount of air that you have left over after you squeezed every last drop of air that you think you can squeeze out, you still have some leftover air. That leftover air is called residual volume. You can't get it out. Now, I suppose if you were attacked by a giant anaconda and that thing started to wrap itself around your rib cage and it squeezes and squeezes and squeezes and squeezes, eventually it's going to squeeze all the air out. You won't be able to breathe in. You will suffocate. That's the point of the anaconda. I would recommend avoiding anacondas for that reason. But that's what they do. They squeeze out that residual volume. So you can't ever breathe out all of the air out of your lungs. You can't. It's impossible. You have about 1 to 1.2 liters of air in your lungs all the time. Can't get it out. All right, so now if we add, now this term called vital capacity, that means that's the air that you can get in and out of your lungs. That's not the total lung volume or total lung capacity. Vital capacity means that's the air that I have access to functionally. But of course then you have the residual volume. If you have residual volume, that's part of lung space. So total lung capacity is your inspiratory reserve, your tidal volume, your expiratory reserve, and your residual volume. Add all those together, that's total lung capacity. So here they are. Here's the values that are associated with those. Tidal volume, 500 mLs. And these are average. These are not universal, but they're average values. Inspiratory reserve, you have a lot more inspiratory reserve than you have expiratory reserve. Almost 3 times as much. Here's the definitions over here. Residual volume, you cannot ever get rid of that. Vital capacity, how much lung volume do I have to work with? How big are my lungs? How much air can they hold? Inspiratory capacity is inspiratory reserve plus tidal, right? So 3,000 plus 500, 3,500. Yes, of course. Total lung capacity, you add all these up, you get about 5 to 6 liters of air. So, look through that chart, understand how to get all of these different capacities. What do they mean? Here's the definition of them over here. All right, so we have some what are called dead spaces or dead air spaces. Anatomic dead air space, that's air in the respiratory tract that remains in the conduction structures. Remember, dead space simply means that air is serving no purpose. It's not in a functional space, it's not getting gas exchange, it's in basically the duct work or the tube work of the lungs. So it serves no functional purpose, no physiologic purpose. So anatomically, it's in a dead space, right? It does not reach alveoli. Alveolar dead space, now it turns out that there are non-functional alveoli. Why would that happen? These can be alveoli that are associated with capillaries with very poor blood flow. It occurs occasionally. It tends to be a factor of aging. Of course, it's going to be a factor in lung diseases, smoking, miner's lung, where you start to kill alveoli, and alveoli become non-functional, and so, but they're still taking up space, and so that becomes alveolar dead space. This is where you're getting no physiologic function. Now, physiologic dead space is the total of the anatomic and alveolar dead space, right? There's no gas exchange here. There's no gas exchange here. If you get no gas exchange, they are physiologically dead. They're useless to you. So, anatomic dead space equals physiologic dead space. For you guys, for people who have healthy, youthful lungs, you really don't have very much alveolar dead space. That happens with age, or it happens with things like smoking, or if you worked in a coal mine, or something like that, where somehow you're destroying alveoli, and that increases over time. But normally, under normal circumstances, anatomic dead space equals to physiologic dead space, and that is about 150 mils per breath. So 150 mils of air is sitting inside the ductwork in your lungs. All right, so alveolar ventilation. That means how much air is an alveolus seeing every minute. Volume of new atmospheric air moved into the respiratory passages each minute. Okay, so here we call that minute respiratory volume, MRV, the minute respiratory volume, how much air the alveoli are seeing every minute. So that's tidal volume times the respiratory rate. So how much air are you bringing in, and how fast are you breathing? All right, so if the tidal volume was 500, and you were breathing 20 times a minute, you've got 10,000 milliliters of air reaching your alveoli. So some of the new air in each breath remains in the physiologic dead space. Another figure can be calculated to represent the actual amount of inhaled air that reaches the alveoli each minute. So this is sort of a dreamscape. This would be like the dream number, like this would be the maximum amount of air that you could actually get into the alveolus under ideal circumstances. It turns out that there is physiologic dead space in the lungs that isn't contributing to air. You're not getting anything out of that. So we calculate another figure called the alveolar ventilation rate. So alveolar ventilation rate is tidal volume, right? So you're at rest, in and out, minus the physiologic dead space. Then you multiply that by the breathing rate. Right? So here it is in algebraic form. Alveolar ventilation rate is respiratory rate, RR, that's how many times you're breathing in a minute, times the tidal volume minus the physiologic dead space. This is the volume of air that actually reaches. I would put that word in, that actually reaches the alveoli each minute. It's an important value, and it impacts the concentrations of O2 and CO2 in the alveolus. Very important. Now, you have other things we refer to as non-respiratory movements. Non-respiratory air movements are anything other than breathing. So, laughing, ha 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 ha, crying, coughing, don't worry, I coughed into my elbow, you're fine, sneezing, achoo. This has an effect on respiration, but it doesn't, or it has an effect on ventilation, but it doesn't have an effect on your ability to exchange gases, and so we refer to them as non-respiratory. The point of these movements is not to get air in or out, it's some other purpose. A lot of times reflexes, but they can be initiated voluntarily. Sneezing is usually not initiated voluntarily. Coughing usually isn't, but can be. Laughing, you can voluntarily laugh or not laugh, but it may feel involuntary at certain times. But anyway, those are called non-respiratory movements. So here they are summarized. Coughing, sneezing, laughing, crying, hiccuping, yawning, and speech when you're talking. That's a non-respiratory air movement. You're moving air. That's what I'm doing. I'm pushing air out of my lungs through my vocal cords. But I'm not, that doesn't have anything to do with my respiration. So there's a summary of those. Okay, the control of breathing, we're going to talk about that in the next slideshow. That's going to get more into respiration and what's happening at the alveoli, and then the central nervous system control of breathing will be included in there. So look for that on the next slideshow, lecture show.